like it is like a million years away, but it's gonna come so fast.
Talking about burn
and it's
coat.
tons of fun. It's like the best time ever. Oh, you are talking about coat burning?
Yeah.
Oh, I thought you were about lawn coat. Never mind. Coat burning is pretty incredible too.
I'm more excited for that experience.
I can tell y'all so many stories about my coat burning. No, I would get in so much trouble, but I hope y'all this is wicked as ours was. I will tell you this, that the president of my, well, I can tell you that, he's not here anymore. The president of my class, I vaguely remember on the bus ride back, he was like half body out of the bus, and he was vomiting all the way down the side. Yes. But he was like screaming the whole time because he was so happy, and we were all like, yeah! And there was a girl in my class that I think kissed half the single guys in my class that day. That was just bad. It was bad. It was bad. How do y'all do this memorable as mine was?
Challenge accepted.
It was fun.
That was so funny.
Okay. Alright, we're going to pick up with V2.
Sorry, RJ.
Okay? We're going to pick up with V2. So, this is maxillary. It goes to the foramen rotundum.
I'm going to be that.
Right after it leaves the foramen rotundum, it drops down here to the pterygopalatine ganglia. From the pterygopalatine ganglia, you've got 3 different nerves. You've got the one that's going anterior or forward. It's the nasopalatine. And then you've got the greater palatine and the lesser palatine. Every nerve I've got drawn up here is what kind of nerve? Sensory. Good. Okay, so these are sensory. This is sensory to the nose, the septum, and then this, the nasopalatine, is actually going to exit out the incisive foramen. So everybody's seen that on your skull, right? You take your skull and you turn it upside down. It's that little hole back behind the first 2 incisors in the roof of the mouth. Greater palatine and lesser palatine are going to go out the greater and lesser palatine foramina. So they each have a foramen named after them. The greater palatine is going to do sensation to the hard palate. And the lesser is going to do sensation to the soft palate. The nerve that continues straight is infraorbital. Have y'all gotten this far in lab yet where you like chip away the bone and you can see the infraorbital nerve going through the maxillary sinus? Okay, good. It's going to exit out onto the front of the face, out the infraorbital foramen, and what it does, it's going to trifurcate into 3 different divisions. It's the inferior palpebral, nasal, and superior labial branches. So those are doing exactly what they sound like. Inferior palpebral is doing right underneath the eye. Nasal is doing on the bridge of the nose, and then superior labial is doing the top lip. This is a really common one for them to tag in the lab. Okay, so if you peel away that part of it should be already gone, that part of the skin coming out like right here, you can see it. And if they tag it, they're not wanting you to name these. Okay, they're just wanting you to name infraorbital nerve. Okay? They're not going to try to get you those tiny little branches. If they are trying to get you the tiny little branches, it'll have to be one that has them all intact going to their places. Okay? And I doubt any of you have that. So usually it's like cut off, coming right out of the foramen, and they'll tag just the end of it. If I can spell. Okay? And then you got a branch that goes upward off of the infraorbital. That's called the zygomatic. And it's going to branch into two divisions, the zygomatico-temporal and zygomatico-facial. Some of your skulls actually have those tiny little holes on the side over here in the zygomatic area. Some of you won't, but you might see a tiny little hole. They're not going to tag something that small. And again, these are doing sensation over this area of the face. Okay. Coming off of the infraorbital nerve as it's coursing through the maxillary sinus, you've got three. I'm going to kind of overlay them on top of this because they're kind of running in the same plane, okay? And we'll try to not make it confusing. So you've got three main divisions. Okay. These, let me get an eraser. So these are your superior alveolar nerves. And you've got an anterior, middle, and posterior. So that's kind of a long word, okay? So you've got a posterior, superior alveolar nerve. You can just kind of remember that the superior, alveolar means teeth. So superior teeth, the top teeth, okay? So these are the nerves that are giving sensation to the top teeth and gums. And you've got three going from front to back, anterior, middle, and posterior. If that makes sense. So again, these are doing the sensation of the teeth and gums, the top teeth, okay? Okay. So again, everything up here is sensory, right? There's nothing motor up here. These are all sensory nerves. However, remember that your post-ganglionic parasympathetics, which are GDE, ride branches of cranial 5 to get to their destination, right? So you've got some of that happening. So let's go through what those are. All right. Pterygopalatine ganglia. It is going to receive preganglionic fibers for cranial nerve 7. Okay? So cranial nerve 7 is going to send its preganglionic fibers there to synapse. We'll talk about that when we get to 7 at the next one. Now you've got postganglionic fibers from the pterygopalatine ganglia that need to get to their target. Okay? So it's going to do two different things. The first set are going to go down these three main nerves that you've got leaving the ganglia. So again, these are post-ganglionic parasympathetics. They are GVE. Okay? So preganglionics from cranial nerve 7 are going to synapse on the pterygopalatine ganglia, and then it's going to send postganglionic parasympathetic fibers to their destination. They're going to ride branches of cranial nerve 5 to get there. When some of them leave, they're going to ride the nasopalatine, greater palatine, and lesser palatine nerves, okay? So those GDEs are going to go do mucus production in the nose and the gums, like the roof of the mouth.
Can you say that again, mucus production?
So it's mucus production in the nose and then the palate, like the roof of the mouth.
Thank you.
Yeah. All right, so that's one set. Then you've got a different set. Again, these are postganglionic parasympathetics. They're going to leave, and they're going to go up, and they're going to hop on the zygomatic nerve. And then they're going to go up to the zygomatico-temporal nerve. then this is where people get confused, and I don't think I can reach that far. From the zygomaticotemporal nerve, they're going to hop off of it and on the lacrimal, which is B1. Remember? Go into the lacrimal gland. So back when we did, remember back when we did the lacrimal nerve, and I kept saying over and over and over, the lacrimal nerve is only sensory. Remember? It's only doing the sensation to the lacrimal gland. Well, because the lacrimal gland itself is innervated by cranial nerve 7. Okay? So what happens is these postganglionic parasympathetics are going to leave the pterygopalatine ganglia, and they're going to ride branches of cranial nerve 5 to get to the lacrimal gland. The pathway it takes is the zygomatic nerve to the zygomaticotemporal to the lacrimal to the gland. Sorry. So that's where people sometimes get really confused about what's happening at the lacrimal gland. Okay? The lacrimal nerve is only sensory. It's distributing postganglionic parasympathetics from cranial nerve 7 that are riding it to go innervate the gland, to give motor to the gland. Okay? But the lacrimal nerve is only a sensory nerve. Does that make sense? Does that not make sense to anyone?
What is that nerve called that leads from C is 7? Is that certain names?
We'll get there. It's quite a few names.
It's separate from the
It's separate. We'll get there when we do 7. And I'll put it all together for y'all. Like, I'll write it all out for you.
Future me. That's me.
Okay. Alright, does that make sense? So these are all sensory, and I've just drawn you out in purple the postganglionic parasympathetic GDEs that are riding these branches to get to their targets. These 3 and this one. Okay. Everybody with me?
So that's all from cranial nerve 7.
All of the purple is from cranial nerve 7. So cranial nerve 7 innervates the lacrimal gland, and cranial nerve 7 innervates the mucus production of the nose and the palate. Okay? So this one has quite a few branches, so just hang with me, okay? Okay. So V3 is going to leave the foramina valley. So when it leaves the foramina valley, the first little branch it gives off is the nerve to the tensor veli palatini. Remember, it lives up there kind of by the palate. So before it goes anywhere, it's going to pop off that nerve going to that palate muscle. Okay. The next thing it's going to do, it's going to give off another one that wants to get back up in the head. So this is a meningeal branch. It's going to leave and it's going to go back up into the cranial vault by going through the foramen spinosum. Okay, and its responsibility is to do some, not all, just a part of the sensation of the middle cranial fossa. The next one you've got is the nerve to the tensor tympani. I'm going to go back over these, okay? Because I'm just doing abbreviations for the sake of room. All right, so you've got V3 leaving the foramen ovale. It's giving off a branch going to the nerve, which is the nerve to the tensor veli palatini. And then you've got another branch coming off that's going to, because we've exited the cranial vault, right? So what happens is it needs to get back up in there. So it needs to get back up in there, and it goes back up through this foramen spinosum. And that is the meningeal branch that's going to go help do some of the sensation to the middle cranial fossa. You've also got a little branch coming off, which is the nerve to the tensor tympani. And then the next little part that you've got are all the branches to your muscles of mastication. Deep temporal, your mesenteric, and your nerve to the lateral pterygoid and nerve to the medial pterygoid. Your deep temporal is actually going to branch into two divisions, an anterior and a posterior. Okay, so those are doing your muscles of mastication. After it gives off the nerves to the muscles of mastication, it gives off the nerve called the buccal nerve. Okay. This buccal nerve is not the same thing as the buccal nerve from cranial nerve 7, the buccal branch from cranial nerve 7, okay? They both have the same, they're both buccal nerves. This one is just sensory. Okay? The one from cranial nerve 7 is motor. Okay? So, we'll talk about it a little bit more when we get to 7, but this is just doing sensation to the inside of the cheek. Okay? So that we got buccal. So now when you get about right here, it's going to split into two different sections. I'm sorry, I don't have able to see this very well. Okay, so everybody should somewhat recognize this picture. So in the lab, you cut off part of the mandible right here. You know what I'm talking about? And you should be able to see the lingual. And right here, you should be able to see the inferior alveolar. And then a lot of you have this tiny little nerve that's running right beside the inferior alveolar in lab. Does everybody know what I'm talking about? Nerve to the mylohyoid, absolutely.
So this isn't the same as the lingual nerve that in the cordyceps, correct? Is that something different?
So yes, but cordyceps is not 5, cordyceps is 7. But they run together, so they run kind of parallel to each other. But the lingual nerve is cranial nerve 5, cordyceps is cranial nerve 7. But they run right beside each other. They're going to the same place.
Okay.
Okay? So everybody should kind of know at least spatially what I'm talking about when I'm right here, because you should be able to see this in the lab. Okay? Make sure you see this little branch, this little nerve to the mylohyoid in the lab, because they're going to tag it. Okay? It's right beside the inferior alveolar. So the lingual is going anterior towards the tongue, and the inferior alveolar is going down towards the inside of the mandible. Okay? And this little thing is pretty small. But if you take your probe and you try to You can actually separate them out on most people. Some people, it won't branch until later, so you might be too high to actually see the branch. But I know that some of you have this, so just make sure if you haven't seen it that you see it. Okay, they're going to tag the nerve to the mylohyoid on somebody's body.
Dr. Heather,
Yes.
tell them table 18 has one.
Table 18 has one. That's a good one. Thank you. So this nerve to the mylohyoid is doing the mylohyoid, and it's doing the anterior belly of the digastric. So it's doing both of those muscles. Okay? The inferior alveolar is going to kind of go back on the inside of the mandible, and it's going to go through the mandibular foramen, the hole on the inside of the mandible. Okay? And then it's going to, when it does that, it's going to run inside the bone of the mandible. So has everybody seen that on your bone? Have you seen that, the mandibular foramen? Okay. So that's what the inferior alveolar nerve is going through. It's going to go inside the mandibular foramen. Okay? When it gets inside the mandibular foramen, it's going to give off all these tiny little nerves to the teeth down on the bottom. That is your inferior dental plexus. And I didn't draw it earlier, but when I connected all the ones from the superior, that was your superior dental plexus that went to the top teeth. Okay, so I'm going to say all that again. So it splits into the lingual nerve and the inferior alveolar nerve. The inferior alveolar is going to give you nerve to the mylohyoid, which is going to innervate the mylohyoid and the anterior belly of the digastric. Okay? Then the inferior alveolar is going to go through the mandibular foramen, and inside the bone of the mandible, it's going to send all of its sensory fibers to the teeth and the gums. Okay? Those are going to form your inferior dental plexus. It's going to exit the mandible out the front of the chin, out the mental foramen. Everybody has seen that on their skull, right? The mental foramen. If you take this skin right here in the lab and you peel it off, you can actually see the mental nerve coming out of the mental foramen in the lab. That's fair game too. So again, inferior alveolar nerve is going to dive into the mandible, give off the inferior dental plexus, exit out the mental foramen, and become the mental nerve. And you can see it right here on the front of the chin.
When you were talking about the superior alveolar nerve, is that
Yes.
the same thing as posterior superior alveolar nerve?
So there's three different superior alveolar nerves. There's an anterior, middle, and posterior superior alveolar nerve. They come together and form the superior dental plexus. They all join together. There are three superior alveolar nerves off of each tooth. All right, y'all hang with me. All right, lingual nerve is going to keep going to the tongue. Yes.
Is the superior dental plexus the same thing as the superior alveolar plexus?
Yes, it is the same. All right, the lingual nerve is going to keep going to the tongue. Let's talk about what the lingual nerve is doing, okay? So I'm going to do a little star because I'm going to write some stuff and I don't have room. All right, lingual nerve. This is another place where people get really confused. The lingual nerve's function is sensation to the anterior 2/3 of the tongue. Okay, that's what the lingual nerve is doing. So tactile sensation is like if you bite your tongue and it hurts, the lingual nerve told you it hurt. Okay, so tactile sensation. Okay? However, it's got some other things associated with it that cause people to be really confused. Okay? Riding, like not even riding, just going right beside it, like touching it, its entire course to the tongue, almost its entire course, you've got another nerve that's running directly beside it. Okay? That nerve is the cordotympany nerve. The cordotympany is from cranial nerve 7. And it is doing taste to the anterior 2/3. Okay? So 2 different types of sensation to the anterior 2/3. You've got tactile sensation, which is the lingual. But running right beside the lingual nerve, you've got a branch of cranial nerve 7 called the cordotympany. The cordotympany is going the exact same place, but the cordotympany is doing taste. Okay? So the lingual nerve does not do taste. It only does tactile sensation. Okay? Don't get confused by that. Alright? Also, what the lingual nerve is doing is right about here. You've got the submandibular ganglia. Okay? The submandibular ganglia pay attention. The submandibular ganglia is going to give postganglionic parasympathetics that are going to ride the lingual nerve to get to the submandibular and sublingual glands. Okay? I sure will. So the submandibular ganglia is going to give you postganglionic parasympathetics that are going to ride the lingual nerve to get to the submandibular and sublingual glands. Okay? Those fibers are from cranial nerve 7.
Is it the cordotympany that it's from?
Yes, it's from the cordotympany. The cordotympany is carrying it there. That's correct. So they run through it, but they don't do anything in it. Yes, they just essentially pass straight through it and keep going to the tongue. Yes. Okay, so we'll say that again. So all of these things are associated with the lingual nerve, and that's how people get confused.
Does the cordotympany join before the ganglia?
Yes, the cordotympany essentially runs like directly beside the lingual, like all the way up here.
Okay.
Yeah, the cordotympany is usually so small that you can't see it. I will tell you this, and we're kind of jumping ahead because cordotympany is 7, but has everybody seen the little model of the inner ear that he carries around? It's like super precious to him. And it's got like a part of the bone, and you can see like the semicircular canals, and it's got like a black thread. Okay, they're going to tag, they've done it every year, they've tagged the black thread, and you're supposed to know that that is the cordotympany on that model. Okay? Okay, so on that little model, that tiny little black thread on the inner ear model, that is the cordotympany nerve. Okay? Just don't miss that. Okay, so again, the lingual nerve is kind of doing all these things. But its function is sensation to the anterior two-thirds of the tongue. General tactile. It is riding beside the chorda tympani, which is doing taste to the anterior two-thirds of the tongue, and it's distributing postganglionic parasympathetics to the submandibular and sublingual glands. Alright. That makes sense how those things are all happening at the same time, but they're very different from one another? Okay. Yes.
I have a question.
Yes.
So is it the same concept about basically that nerve fibers like to ride trigeminal? Because technically lingual nerve is trigeminal, but
Right.
it's carrying the sympathetics from cranial nerve 7. So is that
Sympathetics.
parasympathetic?
Parasympathetics, right. Yeah, so this is the same thing. This is just the parasympathetics riding the branching cranial nerve 7 to get to their target. Is that what you're asking?
But it's riding 5 because it's lingual nerve, right?
Right. It always rides 5. Always. Postganglionic parasympathetics always ride a branch of cranial nerve 5 to get to their target. Always. Alright, one more branch. Up here. Up here you've got a funny little nerve called the auriculotemporal nerve. No one ever needs to miss this nerve in the lab because it is the only nerve that does this super weird thing. So when it branches off the main nerve, it actually sends part of the nerve behind and part of the nerve in front of the middle meningeal artery. It literally splits itself in half, wraps around the middle meningeal artery, and then joins back together and keeps going. Anybody seen that in lab? Okay, yes. So some people have their hands up. That means everyone in this room needs to find it in the lab. Okay? No one needs to miss it because it's the only nerve that does that. Literally, it's like the artery's going like this. Okay? So it splits itself around the middle meningeal artery.
There's a prosected face that you can see this nerve in the artery very well, but the artery does not go through it. You can see it split, but for whatever reason, the artery misses the hole.
That's funny. But you can see the nerve like split around?
You can see the nerve, it's split, but the artery doesn't go through it.
That's weird.
That's the one that I saw.
That's the one that you saw. So y'all make sure that you understand this relationship because it's a fair tag in the lab and there's no reason to miss it because it's super weird. Okay? Yes?
You said chorda tympani drops off the pre-ganglionic.
Yes. Yes. Yes.
So that's why we'll talk about that in 7.
Yes.
They have all these questions about
that's my
is it cut
table.
forward or after.
Yes. What it's doing.
But we'll talk about that in 7.
We'll talk about it in 7. Okay.
All the TAs like
Y'all hang
to
with me.
this really good stuff.
So all these branch-joined muscles because it's the motor component, right?
Yes, we'll talk about that before we leave it. I'll show you exactly which one's doing what.
Really?
Okay, auriculotemporal.
That's your table?
The auriculotemporal has a ganglia associated with it. It is the otic ganglia. Okay? So let's talk about what it's doing. The otic ganglia is sending postganglionic parasympathetics from the otic ganglia. Their preganglionic fibers came from cranial nerve 9. So cranial nerve 9 is going to send its preganglionic fibers to synapse on the otic ganglia. Then the otic ganglia is going to send its postganglionic fibers to ride the auriculotemporal nerve to get it is essentially connected to it. Yeah. So the otic ganglia sends postganglionic parasympathetics to ride the auriculotemporal nerve to get to the parotid gland. Okay. So the parotid gland is innervated by cranial nerve 9. Okay? Cranial nerve 9 is what's giving motor input to the parotid gland. Okay? It sent its preganglionic fibers to synapse on the otic ganglia, and then those postganglionic parasympathetics, which are GBE, are going to leave the otic ganglia and ride a branch of cranial nerve 5 to get to their destination. That branch is the auriculotemporal nerve, and their destination is the parotid gland. So remember that V3 is a mix of sensory and motor, right? So the motor component of V3 is the SVE that came from pharyngeal arch 1. Good. So those are going to be here. The nerve to the tensor veli palatini. SVE's here to the muscles of mastication. Here to the nerve to the mylohyoid and the anterior belly of the digastric. And here to the nerve to the tensor tympani. So those are your motor branches, okay? Everything else is sensory. I'll say those again. It's the nerve to the tensor veli palatini, your muscles of mastication, which are the anterior and posterior division of the deep temporal, the mesenteric, and the nerve to the medial and lateral pterygoids. Nerve to the mylohyoid, which also services the anterior belly of the digastric, and the nerve to the tensor tympani. So those branches are going to be carrying SVEs. There's a motor to those special muscles that came from pharyngeal arch 1.
Carrying sensory and motor.
Some of them are, but you do not have to weed out the differences. For the most part, it's just motor. If you can just remember, those are motor. Okay? Let's see if there's anything else I want to tell you. Okay? So we've done some clinical. Let's do a couple clinical things. Trigeminal neuralgia. Sometimes you'll see this called tic douloureux. That's just another term for trigeminal neuralgia. So trigeminal neuralgia, it's kind of a phenomenon. It's not completely understood, but it's where the sensory feedback that's coming in, it's usually V2 to V3. The sensory input that's coming back in starts relaying pain. And so what happens is the patient will actually start having excruciating pain. So they'll come in and they'll have really bad tooth pain and cheek pain and jaw pain. And there's some people think it's a virus that kind of infected the trigeminal ganglia. And some people say they just don't really know what it is at all. So it's not completely understood, but it's pain that's carried on usually V2 or V3. And the problem is that they come in, and if it comes in and they think it's tooth pain, they'll like go to the dentist, and the dentist will do this huge workup, end up like pulling teeth that they don't need to pull, and nothing gets better, and they end up realizing that it's just tic douloureux or trigeminal neuralgia. And so what you can actually do is you can go in and you can radio ablate the trigeminal ganglia, so this big thing. Because remember, this is holding all of our cell bodies of our sensory fibers. So they'll actually do like radiation therapy, directed and targeted right here, and they'll essentially kill off all those nerves. Because somebody would rather live without pain than to live with sensation. Okay? You can also go in and do injections, where you inject medicine that kind of numbs it up, but that's only transient, it doesn't last forever.
Would that affect the muscles?
So yes, it will cause weakness on that side, yes, depending on how much you do. Like if you damage the whole thing, then you're going to damage the nerves going through it. But for the most part, some people, like you can still chew on the other side, and they don't do it like completely. So that's one thing you'll see. Something else you'll see is zoster, or herpes zoster. So this is like the sister of chickenpox. Okay, so zoster or shingles is what you've probably heard it called. Anybody have shingles? It is horrible. Okay, so what happens is you have the shingles virus and the zoster virus in your body, and it lays dormant in your ganglia. And then whenever your body is stressed, it'll kind of come out and like rage its ugly head. And what happens is it always follows a dermatologic distribution. So that's why you probably learned about it when you did thorax and abdomen, like you had the classic like wraparound dermatome with shingles. So the same thing can happen on the face. So it can actually go in and infect the part of the face that's V1, V2, or V3. The part that's really bad is if it gets V1. So if it gets V1, it can actually get inside the eye and in the orbit and on the cornea. And you can actually get like herpetic, like vesicles and ulcers like on the eye itself. So a long time ago, what they used to do is when somebody started like getting shingles in that distribution, they would actually sew their eye shut so that it couldn't move from the outside to the inside to protect the eye. It's bad. We don't do that anymore. We don't sew any eyes. But it's bad because it can cause corneal ulcers and abrasions and scars, and you can like have vision loss because of it. Okay? Make sure you understand the difference between damage to V1, V2, and V3. Okay? So if you damage V1, let's talk about V1. So it's this distribution, right? So if you damage V1 and I poke your eye, can you feel it? No. Can you blink your eye?
Yes.
Yes. Can you move your eye?
Yes.
Yes. Okay, right? So you only lose the sensory component. Okay? What about, let's talk about V2. So if I damage V2, can I feel you poking in my cheek and on my zygomatic area? No. But can I blow up my cheek?
Yes.
Right. What? That's 7. That's facial. Yes. So the motor to that area still works. You just lose the sensation to that area. Okay? So V3. So V3 would be like the mandible and the bottom part of the jaw. So if I lose V3, can I feel somebody touching on my jaw? No. Can I move my lips? Yes. Because that's what? Parameter 7. Absolutely. Can I chew on that side? No. Okay? Absolutely not. So what does that look like? So when somebody damages V3, what happens is when they open their mouth, you've got essentially like one side of the mouth that won't allow the jaw to open very well and one side of the mouth that will. So what happens is the strong side overwhelms the weak side, and the jaw will actually deviate to the weak side. So think about it as the strong muscles pushing themselves against the weak muscles, and the weak muscles aren't there to hold it straight. So the jaw will actually deviate to the weak side when they open their mouth. That makes sense? So they open their mouth, and the strong side pushes the jaw towards the weak side because the weak side can't keep it straight. Okay? So the jaw will deviate to the weak side when they open their mouth. They can still chew on the other side. The other side works, so they can still kind of open and close their mouth. It's just really weak. Okay? Can they move their tongue? Yes. Right? Because that's what? Right, that's 12. Okay. Can they blood their cheeks? Yes. Why? Facial. Okay, I just want you to make sure you understand what you're losing and what you're keeping. Okay? Yes?
If you damage, like, if you put the jewel, does that affect the parasympathetics as well as the nerves as well?
It depends on where you damage it. Yes. So if you damage any part of one of these branches that are carrying these GBEs, if you sever the nerve, then you are going to lose the input to the target. Okay? So just like, think about the sympathetics. The sympathetics are riding on the internal carotid artery. If I chop the artery in half, I've lost the ability of my sympathetics to get where they're going, right? It's the same thing. So if you sever any of these nerves that are carrying these GBEs, and you cut those nerves, you cut those GBEs with it. Okay?
If you severed it, like, right as it's leaving the ganglion, your parasympathetic distribution is fine, right? Since it's just riding.
If you sever the nerve anywhere after the ganglia, you've lost your GBEs.
Well, also like the trigeminal ganglia.
Oh, up here.
If you like sever
Yeah, so that's a tricky question. So the answer on your test would be everything would be fine. But in real life, when nerves don't have input, they wither away and die. So like they will essentially necrose and go away. And then it will just be hanging there without anything to follow. So you'll eventually lose it. But in that moment, you'll still have it because the structure will still be there. The structure just won't work. You're not going to have that question. That's too hard. Okay, but you might have the question that asks you about cutting one of these. Okay? So if you sever one of these branches that are carrying your postganglionic parasympathetics, you've lost your parasympathetic input. Okay? All right, so how do we test it? So testing is pretty easy. So all you do is you have somebody to close their eyes, and you just take your fingers, so for the sensory part, you take your fingers and you just tell them to close their eyes, and you lightly kind of touch them in each distribution of their face, and you just ask them, can they feel it on both sides, and does it feel the same on both sides? So you just touch the forehead, the cheeks, and the jaw. So that's just a quick cursory sensory test. And then the other thing you do is the corneal reflex. So this is part of cranial nerve 5 and cranial nerve 7. So cranial nerve 5 is your sensory limb, or your afferent limb of the reflex. And cranial nerve 7 is your motor limb, or your efferent limb. So why is that important? So I use this when I do a pronunciation of death. So I do this when I do my exam to show that someone is dead. So what you do, I've never really done it for any other reason, but I bet neurologists probably do it all the time. So what you'll do is, you can take like the tip of a tissue. What I do is I take the tip of my glove, so just put a glove on and like take the finger and pull it out just a little bit. And what you do is you take that little piece of material and you open the eye and you touch the eyeball with that piece of material. Okay. The sensory limb of cranial nerve 5 tells you that something is touching the eyeball. So it's sensation. It senses that there's something in the eye. Okay, so this is a protective reflex. So it goes and talks to the motor limb, which is cranial nerve 7, and tells it to shut the eye to protect the eye from whatever's trying to hurt it or get in it. So you have no control over that. Think about when something like hits you in the eye, you automatically close your eyes, right? Because it's this. This is what's going on. So in someone who is not dead, so if you touch their cornea, their eyelid will blink. Cranial nerve 7 will cause their eyelids to blink. So a lot of times we'll use this when we pronounce people dead, or if they're in the ICU and we're testing brainstem reflexes and they're in the vent, we'll do it there too. So even though they can't talk and interact because we might have them sedated because of the vent, we can test their reflexes and see if their corneal reflex is intact to let us know the brainstem's working. Does that make sense? So again, you touch the cornea, 5 says you touched it, 7 blinks and shuts it, and that's the motor response. All right? So, yes, to see if they're brain dead. The motor, so all that was testing sensation. So to test motor, you can just put your hands on either the masseter or the temporalis and just have them to bite down. And all you're feeling is the contraction of those muscles, either on the side of the cheeks or in the top of up there by the temples. So that's one way.
Can you say that?
Yeah. So you just tell them to close their mouth and to clamp down their jaws, to bite down, and you can actually feel the masseter and the temporalis contract on each side. Another thing you can do is you can have them to open their jaw, so to drop their jaw, and to push their jaw the other way. So if somebody who's got normal muscles, their jaw shouldn't move. That they should be able to resist you pushing their jaw with their mouth open. So if I were to open my mouth, push against their mandible. So in a normal person, that shouldn't deviate their jaw. But in someone whose muscles of mastication don't work, you'll be able to push it against the weak side. Does that make sense? There's another reflex. It's kind of a weird reflex. It's called the jaw jerk. It's weird because it tests motor and sensation of the same nerve. So it tests V3. It tests the sensation of V3 and the motor of V3. So what you do is you have them to open their mouth, and you put your finger right on the center of their mandible. And with your reflex hammer, you tap your finger. And what happens is the sensory limb of V3 feels that tap, and the motor limb of V3 will reflexively clench the jaw. So they'll actually bite down a little bit. They won't slam their jaw shut, but you'll actually see their mouth kind of bite down a little bit. So this is actually testing V3's motor and sensory with one reflex. There's the jaw jerk.
Can you repeat that?
Sure. So you have somebody open their mouth, and you just put your finger in the center of the mandible, and with a reflex hammer, you tap your finger, just like you would if you were doing the patella. And the sensory limb of V3 feels it, and the motor limb of V3 reflexively clenches the jaw, so you'll actually see the jaw kind of shut a little bit. So it's sensory and motor for V3. Take 5 minutes and we're going to knock out 7 and maybe 8. Yes, 7 and 8 for sure.
I'm just going to be watching it.
When you saw loans kicking on January 1st?
Get a good center.
Down in front.
You are? Okay.
Saturday, just soon as totally.
Facial. So for the facial nerve, it's cranial nerve 7. Its name is the facial. Motor, sensory, both. Good. It's got a ton of fibers. So if you look at your little table that you want to memorize over there, you can see that 7 goes all the way across the middle columns. So it's got 5 different fiber types. I've written out for you what they are and what they're doing. So let's walk through them individually. So we'll do the 2 motor first. So special visceral motor. This is motor to your skeletal muscles that came from pharyngeal arch 2. Okay? So these are like your muscles of facial expression, your buccinator, your occipitalis, your platysma, those. Okay? Vertimus stapedius, all that stuff. Okay? So that's all that's that big list that we did the first night. Okay? The cell bodies of those SBE fibers are found in the brainstem in the facial nucleus. So the facial nucleus in the brainstem is where those cell bodies are. Your other motor component is GBEs. So these are your parasympathetics. So this is motor input to the visceral system. The cell bodies of that system are found in the superior salivatory nucleus. And then I kind of just drew out what's happening. So it kind of sends GBEs down 2 different pathways. The superior salivatory nucleus sends some GBEs to the pterygopalatine ganglia, which then those postganglionics innervate the lacrimal gland and the mucosa of the nose and palate. And then it's got a different subset, but cell bodies are still in the superior salivatory nucleus. It's going to send preganglionics out to synapse on the submandibular ganglia, and then postganglionics from it are going to go innervate the submandibular and sublingual glands. So all of that's GBE. So then you've got your 3 sensory fiber types. The first one is your GSAs. So this is doing cutaneous sensation around the ear, some of the outer ear canal, and some of the tympanic membrane. The cell bodies of these GSAs are found in the geniculate ganglia. Your next type is your SVA. So these are your special sensation. This is taste. We've already talked about it briefly. This is taste to the anterior 2/3 of the tongue, and also to some of the palate. You've got some taste receptors up on the top of the palate, in the back. Okay? And then you've got cell bodies of these SVAs that are in the geniculate ganglia. Your GVAs, so this is visceral sensation, it's coming from the nasal cavity and the soft palate. So think about, remember when we talked about visceral sensation, that's all the like really vague sensory things, right? So it's like super dull, you don't really have very good temperature, it's just like sensations of like pressure and fullness and vague touch. So that's like, this is kind of a weird example. So think about if you have like a big booger in your nose. Like, if it's like really far up in there, you're not exactly sure where it is, right? And so you like get your finger up there and you find it, right? So you can't really tell where it is when it gets far enough back in the nasal cavity. And that's because these take over. That was kind of gross, sorry. My husband would be like, oh my God, I can't believe you said that. You'll remember a weird example. So think about if you have like a big booger in your nose. Like, if it's like really far up in there, you're not exactly sure where it is, right? Until you like get your finger up there and you find it, right? So you can't really tell where it is when it gets far enough back in the nasal cavity. And that's because these take over. That was kind of gross, sorry. My husband would be like, oh my God, I can't believe you said that. You'll remember it, though. Their cell bodies are in the geniculate ganglia. You should notice a trend. Every sensory cell type's cell bodies are found in the geniculate ganglia. Every single one of them. Okay? So the geniculate ganglia acts like the DRG for cranial nerve 7, and it has every single sensory cell body in it. All of them mixed together inside the geniculate ganglia. Question for you. Has anybody asked Sinning or anybody else if you have to know all the different sensory nuclei in the brainstem? They'll just say yes. Yeah, it can be really confusing. That's why, like, I even like question telling you.
Can we
Do you want
find
me
out?
to tell you anyway, and then you just don't learn it if you don't want to?
Yes.
Okay. Okay, so remember me telling you that when you have a ganglia, like a sensory ganglia, that's where the cell bodies are, but nothing is synapsing in a sensory ganglia, right? It's just cell bodies, and they're like the weird, we call them pseudo-unipolar. So the cell body, and then it's got a fiber going out here to the periphery, picking up the sensation, and it's got another fiber going back into the brainstem to synapse on a sensory nucleus. Do y'all remember that? Okay. I'm going to tell you what those sensory nuclei are. I really don't think you have to know them. Okay? But I'll tell you anyway. Why don't y'all ask him? Maybe tomorrow ask him if you need to know him. Okay? So let's just walk through them real fast just in case. First of all, GBAs, they don't have their own sensory nucleus because there's a reflex, remember? They synapse back on this. It's a contained reflex, so they do not have their own sensory nucleus. Okay? They just moderate the output of this. So really the only two you have to know are these. Let me tell you why it's super confusing. Because if you talk about the ear, like the outer ear, the ear canal, and the tympanic membrane, it's got sensory innervation by like 5 or 6 different nerves, okay? It's got super overlap. The reason it gets confusing for people is because even though cranial nerve 7 is getting back some of that sensation, all of that sensation feeds back to the sensory nucleus of the trigeminal nerve. That's why I really don't think you have to know this. This is really more neuro. Okay? But just write it down, and then if you have to know it, you'll have it. Or don't write it down and pun it. Okay? So, essentially, all of the, yes?
Are you talking about the spinal trigeminal tract?
Kind of. So, it gets to be called the spinal trigeminal tract once it gets into the spinal cord. But it's so long, it essentially spans the entire brainstem. So it runs from like the midbrain all the way down into the spinal cord. It's really long. So the part of it that's in the spinal cord is the spinal trigeminal tract. The part in the brainstem is the sensory nucleus of the trigeminal nerve. That's a good question. So just think about it this way. Anything doing sensation of the ear in a cranial nerve is going to feed back to the sensory nucleus of the trigeminal nerve. That's just the easiest way to think about it. Yeah. Anything that's doing sensation of the ear, like the inner ear canal and the tympanic membrane, all of that is sending its information back to the sensory nucleus of the trigeminal nerve. I don't think you have to know this. But y'all see why it's confusing, right? Because it's synapsing on a nucleus that doesn't belong to it. Okay. SVAs, which are taste, they are synapsing on the gustatory nucleus. All taste synapses on the gustatory nucleus, even the taste that does cranial nerve 9. Okay. So ear sensation, sensory nucleus of the trigeminal nerve. Taste sensation, gustatory nucleus. So the reason people get confused is kind of what the gentleman in the back asked me a question about. So if you talk about it, the reason sometimes it doesn't make sense to people is if you draw out the brainstem, a lot of times when we think about these nuclei, they're like contained to one little spot, right? Like this might be this might be the facial motor nucleus. But when you talk about the sensory nucleus of the trigeminal nerve, it runs like this on both sides. And the gustatory nucleus is like half that distance. Does that make sense? So that's why a lot of different cranial nerves can use it, because it spans the entire width of the brainstem. This is neuro. Don't get caught up in this. If I were you, I really wouldn't learn it unless you specifically ask him and he tells you to. Yes?
So that's just they just know the nuclei name, don't know anything else about them.
So he does want you to know that, that these are going to synapse on the sensory nucleus of the trigeminal nerve?
Probably. I mean, this is also from the VA. Like, just know the nuclei, so like, none of the injuries are called parasympathetic or ocular, also anything else about it. In this case, just know the sensory nucleus. The only one I've heard thrown around is. And then.
Yeah, that's good.
Yeah. I think they're probably talking about the parasympathetic nuclei. Those are the ones that you absolutely have to know, or the 4 parasympathetics. Anyway, let's don't spend too much time on it. That's all. That's it. That's all I have to know. So there you go. Exactly.
Oh my goodness.
Okay, let's draw it out.
One of these days.
Give me a heads up. I'm not anymore. I'm willing to cook. Saves my freezer laying before reveal like everything.
Yeah, save some of those for next semester.
I'm not getting eaten at the moment. I have no time.
Okay, so let's just take them one at a time. So this is the facial nerve. It goes through the internal acoustic meatus. Right when it gets in the inside wall of the internal acoustic meatus, you've got the geniculate ganglia. Okay, so that's where you got all your sensory cell bodies. At the geniculate ganglia, it kind of branches itself into 2 main nerves. This one is the facial nerve. And this one over here is the greater petrosal nerve. So let's work with this limb for a second. So greater petrosal nerve. Has everybody seen the greater petrosal nerve and the greater petrosal canal? No. Y'all don't dissect that anymore. You like chip away the bone, and you can see it running, and you can actually see the pterygopalatine ganglia. So some people will actually have it. Make sure you see it, because some people will have the pterygopalatine ganglia, and they'll actually have the nasopalatine nerve and the greater and lesser palatine nerve like coming off of it. So some people will have that in the lab if they did a good dissection. Maybe table 2, maybe. But anyway, the greater petrosal nerve. It's going to leave the greater petrosal foramen. And then, coursing right along with it, you've got the internal carotid artery. What lives on the internal carotid artery?
Sympathetic.
Good. You've got your sympathetics. What kind of sympathetics? Post-ganglionic sympathetics. Beautiful. So they are going to leave the internal carotid artery, and they are going to join up with the greater petrosal nerve. That branch that leaves the artery and joins the greater petrosal nerve has a name. It is the deep petrosal nerve. So what kind of fibers are found in the deep petrosal nerve? Post-ganglionic sympathetics. Good. When they join together, it changes its name to the nerve of the pterygoid canal. That nerve ends in the pterygopalatine ganglia. And like I said, some people will actually have that in lab. They'll have chipped away the bones, and you can actually see the nerve of the pterygoid canal, and you can see the ganglia. And remember what comes off the ganglia? That's a branch of cranial nerve 5. Nasopalatine, greater palatine, and lesser palatine. Somebody in the lab is going to have that. I know that if you haven't seen it, that sounds crazy, but it's there.
Can you name the 3 again that come off?
Sure. So coming off of it are branches of cranial nerve 5, the nasopalatine nerve, greater palatine nerve, and lesser palatine nerve. Those are all branches of V2. Remember what also leaves the ganglia? That's a branch of V2. So pretend like we have superimposed this in the same plane of cranial nerve 5. So cranial nerve 5 touches the pterygopalatine ganglia, and branches of cranial nerve 5 are the nasopalatine, greater palatine, and lesser. So these are not part of cranial nerve 7, these are part of cranial nerve 5. Cranial nerve 7 ends here.
So what type of fibers are the deep petrosal?
Good, so good question. So in the deep petrosal, or in the greater petrosal, rather, you've got from the superior salivatory nucleus, you've got GDEs that go in the greater petrosal nerve that join with the deep petrosal nerve to become the nerve of the pterygoid canal, and they are going to synapse on the pterygopalatine ganglia. Okay? Then we've already talked about what happens after that. So after that, your post-ganglionic parasympathetics that leave the pterygopalatine ganglia are going to ride branches of V2 to get to their targets. Right? So those are going to ride branches of V2 down through the nose and into the palate, and then up the zygomatic to the zygomaticotemporal to the lacrimal gland. So that's the whole picture. So that's them coming from the brainstem in their nucleus going to their ganglia, and then you've got postganglionics that are distributed on V2. And we'll say them again. Okay? So, postganglionics from the pterygopalatine ganglia are going to ride branches of V2. Those branches are nasopalatine, greater palatine, and lesser palatine. That's the one that's going to the nose and the palate, doing mucus.
Is it nasopalatine or nasociliary?
Nasopalatine. Nasociliary is up in the eye. That's D1, yeah. And then you've got some more that are leaving the pterygopalatine ganglia that are riding the zygomatic to the zygomaticotemporal to the lacrimal, to the gland. Do you remember that when we did V2?
What about the fibers that are in the deep petrosal? What are those? You said they're postganglion.
So, in the greater petrosal nerve, you've got pre-ganglionic para. In the deep petrosal, you've got post-ganglionic sympathetics. So if I asked you what fiber types are found in the nerve of the pterygoid canal, preganglionic paras, and it's carrying good postganglionic sympathetics. Good.
Once they reach the ganglion, do the parasympathetic and sympathetics take different routes, or do they just follow the same?
So the parasympathetics are going to synapse in the ganglia. The sympathetics are going to pass straight through it and go to the targets.
But they go to the same, like they go to the same final destinations, or
Yeah.
too much information?
It's too much information. But yeah, you can think of it as doing that, yeah.
Okay, so you're saying technically the nerve to a pterygoid canal is carrying, or it has pre-ganglionic parasympathetic ganglia.
Yes.
But then it also carries post-ganglionic sympathetic. So where does it just carries it until it reaches where it needs to be now?
Right. So they were riding an artery, right? So now they're just riding a nerve. It's the same concept.
So do both of them end up synapsing on the pterygopalatine?
No, these can't synapse because they're postganglionic. They synapse in the cervical ganglia. So they're not doing anything in the ganglia. They're going straight through it to go to the targets. Does that make question?
So the postganglionic sympathetics are not a part of the nerve of the pterygoid canal. They just ride.
Well, they join with the greater petrosal, and when they join together, that joint union is the nerve of the pterygoid canal.
So both fiber types
Are part of that nerve, yes. Because the joining of those two nerves form the nerve of the pterygoid canal. Good. Yeah. Okay. So let's go back to the facial part. So facial nerve. Yes.
Where are postganglionic sympathetics going after they just go through the
That's a difficult question, but I think if I could describe it simply enough. So some of them are going up here to the lacrimal gland, because they're going to make the lacrimal gland slow down production. So parasympathetics are going to make you cry, sympathetics are going to stop it. And then the other ones are going out to the skin. So they're going out to do the capillary beds against the skin. They're going to do the hair follicles in the skin and the sweat glands in the skin. No. It's not going to a particular location. Because remember, like everywhere that you've got skin, you've got sympathetic input. Right. Okay. So facial nerve is going to give off the nerve to the stapedius. nerve to the stapedius, its function is to give motor innervation to the stapedius muscle, and that muscle is responsible for dampening the input of sound. So sound hits the tympanic membrane and it causes vibrations. And if that sound was really, really loud, essentially your stapes would be like pounding itself into your inner ear, right? And so as a dampening mechanism and a protection, the nerve to the stapedius stops that. So it stops you from hearing sound so loud that it would hurt you. Does that make sense? Okay. So also coming off after the nerve to the stapedius is the chordotympany nerve. Chordotympany nerve is going to exit out the petrotympanic fissure. And we've already talked about what it's doing. Okay? It's doing carrying taste from the anterior 2/3 of the tongue. And it's carrying your preganglionic GVEs to the submandibular ganglia. I'm going to say that again. Chordotympany comes off of the facial nerve and the facial canal. It exits the cranial vault out the petrotympanic fissure. And then it joins up with the lingual nerve, going to the tongue. They ride right beside each other, going to the tongue. The chordotympanic nerve has two functions. It does taste to the anterior 2/3 of the tongue, and it sends your preganglionic GVEs to the submandibular ganglia. Then the facial nerve is going to exit out the stylomastoid foramen. And it's going to do a couple things.
Laura.
Okay. So when it leaves the stylomastoid foramen, it's got a few branches. The most important of which is where it kind of gives out all of its branches inside the parotid gland. So it's going to branch inside the parotid gland. And from there, it's going to send motor branches out to the muscles of facial expression, okay? So the branches are temporal, zygomatic, buccal, marginal mandibular, and cervical. If you went to MC, you memorized to Zanzibar by motor car. At least that's what we did. So temporal, zygomatic, buccal,
Please tell Ziggy Bob Marley.
marginal mandibular, and cervical.
Please tell Ziggy Bob Marley.
So if you take the palm of your, like the base of your palm, and put it on your parotid gland, and put your thumb straight up by your ear, and wrap your pinky underneath your chin, and spread your fingers out as far as you go, that falls in the exact distribution of these nerves. So your thumb is the temporal, and your pinky under your chin is the cervical, and everything else falls exactly where it should. You've got 3 other branches coming out the opposite direction. You've got the nerve to the stylohyoid, the posterior auricular, and the nerve to the posterior belly of the digastric. Let me say a couple things about here, 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 here. Everywhere you see red, that is where you have your SVEs. So those are your skeletal muscles from your arch. So that's like your facial muscles of facial expression and all that good stuff. Posterior auricular, it's the one that's doing, it's the funny little sensory nerve that's doing the ear, that's feeding back to the sensory nucleus of the trigeminal that we talked about. Yes?
Is there a more in-depth reason other than the fact that they derive from arches for why they're SVE?
Yep, that is one. Okay, so the nerve to the stapedius, temporal, zygomatic, buccal, marginal mandibular, cervical, nerve to the posterior belly of the gastric, and nerve to the stylohyoid. All of those are SVEs. And then the posterior auricular, it's doing the ear. The GSA to the ear, yeah. It's doing both, actually. It's doing some motor back there to the occipitalis. So actually, I guess it should be there. But it's both. It's motor and sensory. Yes. Thank you. Yeah, it's actually both. All right. Make sure you understand that buccal right here, this is the motor buccal. Okay? This is the one doing the buccinator or the buccinator, however you call it. The other buccal we talked about with cranial nerve 5, it's sensory. To the inside of the cheek, okay? This is motor. Same name, different nerves. Okay? So buccal is important because if babies don't have innervation to their buccinator, they can't suck on a bottle. So it's actually what allows you to like purse your lips together and form like a suction. Okay? So it's super important for babies to have this. Let's talk about injury patterns. Okay. So I'm going to do injury. I guess I'll do it in purple. All right, if you injure here, so if you have an injury of the facial nerve exiting the stylomastoid foramen, what does that look like? So you have full loss of the motor to all the muscles of the face on that side, right? So you have paralysis of the face on that side. Okay? That has a name. It's called Bell's palsy. So Bell's palsy usually doesn't have to be an injury of the nerve itself. Sometimes you can have like viral inflammation of the nerve and just cause it to be so inflamed that it'll stop working. So I don't know if you know of any, like if anybody's parents has had Bell's palsy, or maybe you have had Bell's palsy before. But it's essentially just like if it's a gradual thing from like a viral illness, that side of your face will just slowly get weaker and weaker and weaker, and some people will lose complete innervation, like all the way. But it's the same thing if you sever the nerves, if you cut it or injure it right there. Okay, so you lose the ability to move the muscles on that side of the face. You also lose a little bit of sensation from the ear, but you won't even know that because there's so much overlap to the ear, like we talked about. There's like 6 different things doing the ear, so it won't even matter. Okay. All right. So let's injure here. So now we've injured the chorda tympani, exiting the petrotympanic fissure. So now what have we lost? Taste. You've lost taste to the anterior 2/3 of the tongue on that side. Okay? Remember, there's one on each side. So the other side works. So that side of the tongue, you've lost taste to the anterior 2/3. And you've lost your GVE innervation to the submandibular and sublingual glands on that side. Okay? You've lost taste to that side, the anterior 2/3 of the tongue. And you've lost your parasympathetic innervation to the submandibular and sublingual glands. So your mouth will be pretty dry on that side. You'll still have your carotid. So it won't be completely dry, but you've lost that innervation, all right? So that's 2. So let's add those together and have an injury of the facial nerve in the facial canal. So this is an injury of the facial nerve in the facial canal. So now you've got 1 and 2 combined. So now you've got Bell's palsy on the outside. Can't move that side of the face. You can't taste on the anterior 2/3 of the tongue on that side. You don't have innervation to the submandibular and sublingual glands on that side. But you add one thing to it, this guy. So now you've lost the nerve to the stapedius. That has a name. Hyperacusis. So this, if I had an R. So this, we've now lost the ability of that muscle to protect us from that loud sound. So now everything on that side is excruciatingly loud and it's really painful. So it's like a loud, painful sense of hearing on that side. Okay, so it's 1 and 2 combined with hyperacusis. Okay. So let's add number 4. Nerves the pterygoid canal. So if you lose the nerve of the pterygoid canal, what have you lost? Yeah, you can't make tears. So if you've lost parasympathetics to the lacrimal gland, you've lost your postganglionic sympathetics.
One side of the face.
So and it's not the whole side, it's just up here towards the eye, essentially.
Postganglionic sympathetics.
You've lost postganglionic sympathetics from the deep petrosal, and you've lost preganglionic parasympathetics. Yes?
Is that called chronic drooling?
Chronic drooling is from...
Or tearing, I'm sorry?
So that's a great question. You would only have chronic tearing if you damage here, but this was okay. So you'd have to have unopposed parasympathetics. So to have like chronic tearing, you'd have to lose just your deep petrosal. Does that make sense? Okay. But right here, I've lost both. So it's like my lacrimal gland just doesn't function. It's like dead. Yeah, so when you lose this, you'll have the flushing, and you'll have the lack of sweating, and all that stuff. But you don't have to do like too much about that. As long as the big thing is the lacrimal gland, and knowing that you lose both of these fiber types. Understanding that a lesion of the nerve of the pterygoid canal is going to cause you to lose preganglionic paras and postganglionic sympathetics. Okay? All right, the last one is number 5. That is an injury to the facial nerve at the internal acoustic meatus. You lose everything. So it's everything we've talked about is gone. The big thing that you'll probably get tested about right here is a schwannoma. Y'all heard that? So the most common thing associated with 5 schwannoma. So it's a tumor of the Schwann cells, and it likes to grow right there at the internal acoustic meatus, and it'll knock out 7 and 8 together. Of the Schwann cells. A lot of times you see it with, you'll have to know this, with neurofibromatosis. Those patients have them. And Men's syndrome. Yes. So they give you influenza stuff. All right, so that's your lesions. So how do you test it? So we've already learned one way, corneal reflex. So remember, 7 is the motor limb. It causes your eye to shut. And then the other way you test it so when I was an intern, I guess, I was doing this exam on a patient, and I just started doing it. I didn't really preface it with, this is what I'm going to be doing. And he stopped me in the middle and he was like, why are you having me make all these ridiculous faces? And I was like, oh, let me tell you why, because I'm testing this, and this. So if you have somebody to do this, just explain to them what you're doing. So what you do is you have them, you essentially test the different muscles of facial expression. So you'll have them squeeze their eyes really, really tight, and you'll try to open their eyelids, and you'll tell them not to let you open them. You can also have them raise their eyebrows and squinch their forehead, so you should see lines on both sides. You can have them blow their cheeks up and tell you not to let you push the air out. So someone who can't do that, you'll push and the air will just go straight out if one of their bucinators is weak. You can have them to have a big smile, and the smile should be symmetric and equal on both sides. So just little things like that. That's like the big things that you do. Let's knock out 8. It'll take me 10 minutes.
does.
That's so funny.
Only suspect.
She doesn't.
Oh, yeah.
That's so much internal.
That's too funny. It's like whenever Ashton was like, my pastor.
I ain't gonna study. I know this test.
Have a picture of Adele.
Laura, I failed.
Too clever.
Come on.
I feel like my hair, my right hand is gonna fall off. I wish I was able to run it back.
Helps the aging process.
Oh, okay. That's awesome.
Let's take this.
Well, those are first. I'm hanging on in the back middle for the other.
Okay. This one's real fast. I've done kind of a really bad schematic. So audiovestibular, think about it as two different nerves in one. Think about it doing an audio function, which is hearing, and a vestibular function, which is balance and movement. So they have two totally separate nuclei in the brainstem. So the cochlear nuclei are one set and they're responsible for the hearing, and the vestibular nuclei are another set and they're responsible for balance. There's multiple, there's like a superior, middle, inferior, and all that stuff, but you don't have to know that. Just know that there's a cochlear nucleus, or nuclei, and there's vestibular nuclei. Okay? So this is another one of those nerves that kind of has its own special DRG, right? We've already learned the names of it. So it's got a spiral ganglia and a Scarpa's ganglia. Spiral ganglia is where you're going to have your cell bodies for hearing, and Scarpa is going to be your cell bodies for balance. Both of them are SSA. Okay? So inside these ganglia are the cell bodies of your sensory receptors responsible for hearing and balance. So again, remember, just the cell bodies, and that cell body is going to send out one fiber going out here to pick up the sensation, and the other one is going back to send out to the brainstem, just like all the other ones we talked about. Okay? The reason these are a little bit different is because the way that they pick up sensation, and I'm not going to go through all the different, like, tiny little details because you'll do that histo. They're not going to test you on that at gross, okay? Have y'all done this part in histo? No, okay. You'll do it in histo. But what I want you to know is that the sensory receptors in both places are hair cells. Okay. So, for the cochlear sensation, it's hair cells and something called the organ of Corti. And the vestibular are hair cells in the macula and ampulla. Don't get any more in depth than that. The only other thing you might want to know about the vestibular system is the three different components, like how they're picking up balance. So you've got the utricle, the saccule, and your semicircular canals. So again, these are the little things that he's trying to get you to look at on that little model he carries around. That's like the inner ear. Okay?
Talking about Dr. Butcher.
Yeah. I love him. I'm not being ugly, like I adore him. Utricle picks up horizontal motion. Saccule picks up vertical motion. And the semicircular canals picks up rotational. So hair cells that are in these separate, like, organs out here is what we'll call it, they are going to pick up the sensation of movement by these little hair cells moving depending on which way you move. And that hair cell is going to transmit a signal back to the brain. The cell bodies of each of those are found in these respective ganglia, and they're going to synapse in the brainstem. Clinically, a couple things you need to know is there's two different types of hearing loss. Conductive hearing loss and sensory hearing loss. So conductive is exactly like it sounds. It's something conducting from one place to another. So think about this as like the machinery aspect. So this would be something that's wrong with the ability of the mechanics, okay? So these would be like the stapes and the malleus and all those, okay? So that's like those, if something was wrong with them. The most common thing that causes that is recurrent otitis media. So you keep having ear infections and they end up scarring down. So you actually scar them down so they can't move. And when they can't move, they can't transmit the sound and you can't hear. Ossicles. God, I couldn't think of that word to save my soul. Ossicles. So this is a problem with like the ossicles, the tympanic membrane, right? If you like had a big perforation of your tympanic membrane and you had a big hole in it, it wouldn't be able to actually move back and forth to transmit sound. Okay? So if you have a problem with your ossicles, a problem with your tympanic membrane, the most common of which would be repeated infections, like repeated otitis media. Otitis media is infection in the middle ear. And then sensory is exactly like it sounds. It's a problem with the sensory reception part, okay? So this would be a problem with like the cells themselves. The cells or the nerve fibers or the brainstem. So this would be like a stroke. People who have MS, if their disease gets really bad, they'll lose some of their hearing because they lose the myelin on their nerves and they can't transmit the sound down the nerve. So a stroke would be like the brainstem if you had a big bleed, and if you had a lack of blood supply here and you knocked out these nuclei with a big stroke, you have a sensory hearing loss. If you have MS, you lose the myelin, you have a sensory hearing loss. Those are the most common ones. And we already talked about the tumor right here. Schwannoma. You might also see it called a cerebellopontine angle tumor. I'll write that for you. Cerebellopontine. I spelled it wrong. Cerebellopontine angle tumor. So So that would be the schwannoma we talked about. So if you have something there, you're gonna lose 7 and 8. Okay? And that's usually where it grows. It grows like right at that part where the cerebellum and the pons connect to each other.
But if you were to remove the tumor, you regain.
Well, it depends. It depends on if it was just pressing on the nerve and you took away the press, or had it grown itself around the nerve and invaded the nerve. It really just depends. All right, 2 more things and I'm done. Make sure you look up the Renee and the Weber. The easiest thing is to watch a YouTube video. The likelihood of you getting tested on this is very small, but whatever, for the sake of completeness. These are the ways that you use the tuning fork to tell where the hearing loss is. Renee and Weber. All right, and the last thing. It is on your practical every single year. Okay? You're going to have a picture, a cartoon picture. And it's going to be looking inside the ear. And you're going to see, like, the handle. Yes, you're going to see, like, the handle of the mouse. And what's going to happen is you're going to have this, like, area right here. That's a light reflection, and it's supposed to simulate you looking into the ear with an otoscope. And there's going to be an arrow pointing to this. And it's going to say, what is it? It is called the cone of light.
It's in the book. It's in good.
Who knows? But it's on there every single year. Don't miss it.
They say that it's always
Can y'all meet tomorrow afternoon? At like 5? At 5 tomorrow afternoon?
Yeah, we have a lab, but I mean, we should be able to get out. Like 5:30. 5:30.